Hello. Good evening. Good evening. Sorry for the delay. I'm sorry for the delay tonight. But this will be... Actually, this is gonna be a short topic. Let's see who's here. Tanupat, hello. Prehistoric, hello. Nue, hello. Hello, Pokari. Hello, iMac, hello. Rect, hello. Welcome. Good evening. And I think my chat here... I think my chat is broken. It only stopped at one person saying good evening on the chat. The chat box is broken on the stream. Look at this, only one person. Oh, there we go. Oh my god. Okay, there we go. It's working. There's a delay. I forgot YouTube. I always have a delay here in YouTube. I'm sorry. There's always a delay on YouTube. I never got to fix this because I don't understand YouTube. Hello, Raphael. Hello. Alfred. Hello. Welcome. Mine Skirat. Yeah. Let's see. This is a stream that I was supposed to have last week. Yeah, last week. But I got sick. Like, I had diarrhea. But yeah, we're gonna do this, we're gonna do this now. This is actually relatively short topic because, where I am going to talk about the brain. I think last time I had if I remember correctly, I covered the brain a little bit. Yeah, I covered the brain a little bit. I talked about I had a medical education stream about seizures. If you guys remember that. If you don't remember that one, you can check the playlist. I mean, all my medical education streams here on YouTube are saved in our group together, medical education, so you can just search there. Yeah. Now, before I start this, I think I said this also before on my seizure topic. Last time I streamed about the brain. Neurology or neurosurgery is not my... It's not my forte. I'm not a neurosurgeon. I am a general surgeon. So neurosurgery is a subspecialty. It's more specialized. So the stuff I will be talking about here on tonight's stream are like really basic stuff that a general surgeon should know. So, as a general surgeon, we handle some neurosurgical cases, but very limited. So, you know, especially in cases of emergency, we gotta know this. We have to know at least this. So, some we do on our own, some we have to refer to a specialist. Okay? Fourth year college ka, doktora. No. Bruh. I cannot lecture about this if I'm fourth year college, bruh. Anyway. Yeah, hello 8-man. Okay. Let's see. Oh, and another thing, guys. I don't have a PowerPoint prepared. Last time it was gonna be scuffed, and then when I moved it, I was planning to make a PowerPoint presentation, but then I got super busy. Like this past week was very, very busy for me. Like very busy at work, so I didn't have time to make a PowerPoint presentation. So we're gonna make this. This is gonna be scuffed. This is gonna be very scuffed. I have to list down the most common stuff. Okay. But brain. Okay, wait, let's see. And this is where Google is my best friend right now. Google is my waifu right now. Google. We're gonna look at the anatomy of the brain, okay? Brain anatomy. Oh god, wait, hold on. Oh my god, what is this? Why is this? Oh no, now even my thing thinks I'm a robot. I have to... Okay, there we go. Okay. Ooh, I think this one will help us. I'm gonna open up a photo here, okay? Okay. Zoom. Aha, there we go. There we go. How do we zoom in on this? Okay, I'm gonna flash a photo of the brain, okay? Hold on, guys. Let's start! Okay! Hello! Hello! Alright! So, we got here a color-coded photo of the brain, of the different parts of the brain. Okay, I don't know if... Oh wait, I think it's too small. Let's make it larger. Hold on. Let's zoom in a little bit more. Oh, there. I think that's better now. Oh. Okay. So, this is a photo of the brain. Oh my god, the chat's not working again. Is chat broken? Wait. Oh, there we go. The chat's working. There we go. Alright. So, these are the main parts of the brain. Okay, let me, here's my pointer. So, this is the front of the brain, the red part here. These are the basic parts of the brain. I also discussed this in my last, in my stream about seizures. The front of the brain, here, this red part, is called the frontal lobe. Okay, the brain is divided into lobes. So we have the frontal lobe. There are... Oh, and before that, there are two lateralities to the brain. We have the right and the left hemisphere. Okay, so one right. It is divided by this line here. And we have the left and the right. This is the top view of the brain, okay? This is the underside. This is the left side. So the front of the brain, whether right or left, is called the frontal area or the frontal lobe. Okay? Frontal lobe. And then, on the sides, here, this one, where we have a little protrusion over here, the green part, this one, that's on the sides. It's called the temporal lobe. Okay, there's a left and right, and a little higher over the temporal lobe, which includes this part here. It's multicolored here, unfortunately, but let's just see this part and this part. Okay, or this part. That is called the parietal lobe. Okay, parietal lobe. And then the back of the brain, this one, especially the blue part, is called the occipital lobe. Okay. This part over here, at the bottom, is called the cerebellum. Okay. The large part of the brain that looks like a pile of intestines is called the cerebrum. Okay. And each part of the brain, that's why there's multiple colors here, have a certain function. Like each area has a function. How to say this? And depending on the part of the body. So if you look here, there's even more specialized names here that I learned in medical school but totally forgot about. Especially Broca's area. Oh my god, this one here. Broca's area. If you're in med school, you gotta remember this. This is for speech. Okay? This is for talking. So if you get any damage here in the Broca's area, you won't be able to speak properly. So Broca's area is number 4. It's here. It's near the frontoparietal area. Okay? Frontoparietal lobe. Alright? Okay. And there's also, if I remember correctly, there's also this one area called the motor. This one 3. This one, motor function area. God, I remember this in medical school. There was an actual image for a certain strip here on the brain that tells you, okay, this part of the brain or this strip of the brain focuses on the mouth, the legs, the arms, something like that. The motor part of the mouth. So if you have something wrong there, or any bleeding there, then that part of your body's affected. Excuse me. If it's the occipital area, which is the back, usually this one is more on vision. So if you have any bleeding or infarct or stroke or damage in this area, your vision will be affected. Okay. The homunculus. Yes, Ash. Yes, right. The homunculus. That's what it was called. That was like medical school stuff, man. These are things that if you become a doctor, let's say a general physician or maybe internist or a surgeon or general surgeon, you're gonna forget this this part of medical school. You will just like vaguely remember it, but will not like remember the actual details. Okay. What else? Is this the cerebellum? Is more for balance, if I remember correctly. Yeah. Any bleeding or any damage or here injury to this part, the cerebellum, your balance will be affected. Okay. That includes your posture and your posture. So yeah, each part of the brain. Each part of the brain is very important. If you have a certain if you have a lesion or any problem in that part of brain, it'll definitely manifest as a certain what do you call this? Either weakness on a certain part of your body, or like it can be blindness, or even your balance. Okay? Yeah. Oh god, nakalimutan ko na to. Yeah, don't worry, even I forgot a lot. I forgot a huge chunk of this. Because as a general surgeon, we will only remember only bits and pieces of this. Okay? Because what we need to know is, we don't need to know, as a general surgeon, we don't need to know all of this stuff here. Okay? It is something you learn in medical school, but if you want to be a neurologist or a neurosurgeon, then you would have to know all of this, because if you know all of these, you'll be able to localize a certain lesion. Meaning, just by looking at a patient and seeing what his what do you call this? Seeing what his defects or his problems physically, you'll be able to find out where exactly in the brain the problem is coming from. Okay, like for example, a patient had a stroke. You know, he had a stroke, and he would say, there's a part in my field of view that I can't see. I can't see this certain part in my view. Like, you'll be able to see what's in front of you, but then there's like a certain blank area. Oh, thank you for the sub, Sapphire Forest. There's a certain blank area in your vision. Then you'll know that the problem is probably in the occipital area of the brain. So that's at the back of the brain, because this one's for vision and sight and image perception. Okay? So, okay. The pawns is always the answer. ShioriPons. Okay. Alright, so that's all for anatomy, okay? So, oh, Sep, thank you for sub. Thank you for subbing to my channel. I'm gonna close this now. We got. I looked at brain anatomy focus. Okay. Next. Now we're gonna go to the clinical stuff. Okay? I'm also gonna show you like CT scans. Okay. Now that we know the anatomy of the brain. Oh, I just remembered something. This is also important. Okay? This is also important. Blood supply of the brain. Okay? Blood supply of the brain. This is very important. Now, I don't know if you're in medical school. I think you guys are familiar with what we call the circle of Willis. I just remember this. Oh, here we go. You'll see this. It looks like a stick man made out of blood vessels. This thing, if you're a med student, you gotta memorize this. It's a nice photo of them. I think the best one we have would be I think this would be it. Or is the other one better? This is a better one. Here we go. This right here. Open image in new tab. There we go. Alright. This right here. You gotta know this. You're a medical student. Okay, for those people who aren't in the medical field, but this is something that's nice to know for you guys, okay? This is something, the blood supply of the brain. They call this the circle of Willis. Okay, as in, circle of Willis, W-I-L-L-I-S. We gotta memorize this in med school. It is literally a stick man made out of arteries. Yeah. So if you're a med student and you gotta know this, you gotta memorize this. I remember having this in medical school. They would slap a photo of this on the paper, and then they were like, okay, label all the arteries you see. I'm like, oh god. Yeah, so we have to know that, this is the anterior cerebral arteries. So here at the front we have the left and right anterior cerebral artery. So in relation to the brain, this is the underside of the brain. You can see it here. Basically, it supplies the anterior part of the brain, which is the front of the brain. When you say anterior, it is the front. So you can see it branching up here, anterior arteries, and then here it connects to the middle cerebral arteries. The middle cerebral arteries basically supply the middle of the brain, so you can see it here. Ooh, okay. Oh, and there's a small connection between both anterior cerebral arteries called the anterior communicating artery. Yeah, too much to memorize. Yeah, I know, right? This is what we had to go through in medical school. Literally a blank for this. Literally this without the labels, and you have to label everything. And then if you go downwards, so if there's an anterior, there's a posterior. Posterior means back, so it's going downwards going to the back of the brain. Okay, remember this is the underside of the brain. So we have the posterior communicating arteries, and then it connects to the posterior cerebral arteries, which supplies the back of the brain. Okay. And then you have since this part of the artery, we are here. Where are we? We're here at the. This is like the arms of the circle of Willis. It has a few branches down here, so we have superior cerebellar arteries, and then the pontine arteries. Look at that, little branches right here, and then. If there's a superior cerebellar artery, there's an inferior one, or anterior inferior, and then you got the legs of the circle of Willis, which are the vertebral arteries. These are going down the brainstem and down to the spine, vertebra, vertebra, and then you got the spinal artery. Okay, yeah, we had to memorize this. Okay. Every time I look at the circle of Willis, I keep wondering how people don't get more strokes. It's so delicate. I know, right? I know. And, yeah, this is the... the brain is a very delicate organ. Out of all the organs in the body, the brain is, for me, okay? The brain is the most delicate one. I mean, I think some people think... There are some people who've never held a brain or held another organ, would think another delicate part of the body is the heart. But actually, to be honest, it's not. The most delicate part or the most delicate organ of the body that I have ever touched as someone in the medical field is the brain. I mean, you know why? Because the heart, why is it not that delicate, the heart? The heart is a freaking pumping machine. The heart itself is a muscle. That whole thing in your chest, that chunk of flesh inside your chest that's beating your entire life is a muscle. Imagine that it's a muscle that beats your entire life and you can't control it. It beats on its own. It's involuntary. It's a freaking muscle. And when you hold it while it's beating, you can actually feel how powerful it is. You can feel how strong and powerful the heart is. I've held a beating heart before, like in open heart surgeries. You can feel how strong and powerful a heart is. It's not that delicate. But then when you touch a brain, it's like so soft and mushy. It's soft and mushy. You see, this is why the brain is encased inside the skull. It needs the skull to protect it because it's just soft mush. That's what it is. I feel like any if you just poke on it, you could probably get brain damage just by poking it already. You can get, I feel like just poking your brain will give you brain damage. Yeah. It is freaking soft and mushy. Okay. So someone mentioned aneurysms. Yes, aneurysms. So if you have any aneurysm, an aneurysm is a blockage in a vessel. So a blockage of any vessel in the brain. You would have a clogged artery. So for example, you can have an aneurysm in the anterior cerebral artery. So let's say in the anterior cerebral artery, that would be around here. You can have an aneurysm there. So what happens is there's a blockage. If there's a blockage in the vessels, two things can happen. Okay, two things can happen if there's a blockage or an aneurysm. So let's say you have let's say this. Here we go. My mouse pointer is an aneurysm blocking the blood flow. Okay? It is here in this would be the left cerebral artery, left anterior. Let's say we have a blockage here. What would happen? Two things can happen, okay? But ultimately, whatever happens, it will still end up as a stroke. One, When you have a blockage, since there's a blockage in the artery, what does an artery do? In basic anatomy and physiology, an artery carries blood that brings oxygen to a certain part of your body or to a specific organ, right? So as an artery, it is bringing oxygen to a certain part of your brain. So the anterior cerebral artery is what do you call this? It is supplying the blood supply to the anterior part of your brain, to the frontal part of your brain. So what happens if you have a blockage on the left anterior cerebral artery? If there is no oxygen going there, you can have an infarct. Okay, an infarct is when it's just like in a heart attack. When you have a blockage in one of the coronary arteries, there will be an infarct in the heart, in a certain part of the heart. It's the same with the brain. You'll have an infarct in the brain. So a certain part of your brain dies. Okay, there will be necrosis as the necrosis. Okay. So the damage or the infarct will be on the left part of your brain, left anterior part of your brain, so somewhere in the frontal lobe. Okay, somewhere there, on the left. Okay, that is an infarct when there is no oxygen being delivered there. Another scenario is that if there is a blockage, and you have, let's say, it's usually associated with hypertension. If you have high blood pressure, so there's a blockage here, but then you have high blood pressure, so your blood needs to flow. Your blood needs to flow through that blockage, but it can't. But then the pressure is so high. The pressure is so high that your vessel can't handle the pressure, and it pops. So what happens? You get bleeding, and that's called a hemorrhage. Right? So you'd have a hole here, and you'd be bleeding. So it's not an infarct, it is a hemorrhage. So you would have bleeding into that part of the brain, and you will have bleeding here. Since the blockage is in the left part, you would have bleeding there. It is also a stroke in that case. Okay? It is also a stroke. And based on my experience, that stroke is more of an emergency than an infarct. Okay? If you have an infarct in your brain, that one is not so much of an emergency compared to a bleed. Okay, because when you have in a bleed, remember that your brain is encased in the skull, okay? It is enclosed in a skull, so with it, your skull, just imagine a jar, okay? Imagine a jar filled with fluid, and let's say you have fluid, and let's say you have your brain in there. Or anything soft and mushy that is solid in there, so along with fluid. The jar is completely full and it's closed, right? So what happens? Let's say we introduced what do you call this? A tube into the jar, and then you add more fluid. Okay, where you add more fluid into the jar, even though it's full. Right? Even if it's full. What happens is the pressure will increase. The jar can't expand. It's fixed. It's solid. It's glass or whatever. It cannot enlarge. So whatever fits, if it's a 500 milliliter jar, only 500 milliliters can fit in there, right? Otherwise, the jar would have high pressure inside if you keep adding more, okay? keep adding more fluid when it cannot fit anymore, what happens? You add more fluid. If you have something squishy inside, like the brain, and you keep adding more fluid in there, even though, you know, even if you can't, even if there is no space for it, the brain will adjust to that pressure, okay? Yeah, the brain is going to adjust to that pressure. Since the brain is a delicate, soft, mushy organ, the fluid is gonna push the brain, okay? It'll push the brain, and the brain has no choice but to find a place to squeeze into. Okay. Now the skull is not a completely closed what do you call this, space. The skull has certain areas like holes or foramens. Like for example, the brainstem, which connects to the spine, right? So there is a certain foramen or a hole where this would enter. Okay? So what happens when you increase the pressure? The brain is gonna find a way to squeeze itself in there. Yes, uncal herniation. Hernia. It's going to herniate through the hole. So imagine having, you know, a tight space there. You're bleeding, actively bleeding. So what the blood is going to be taking up more of the space inside the skull, and the brain is gonna adjust by, you know, finding more space for itself, which is through this tiny hole where the brainstem enters. So what happens? It herniates through. The brain is gonna go through that tiny hole, which is not good, right? Imagine squeezing a soft, mushy thing in a small hole. And yeah, and that's actually how a lot of people die from stroke or any like bleeding. It's the herniation, aside from the blood loss, of course. But you know, yeah. So what happens in neurosurgery? We have something like that. What do you do in neurosurgery? We have to. It's an emergency. That bleeding, active bleeding like that, is an emergency. You want to regulate or normalize the pressure, the intracranial pressure inside the skull, because you don't want the brain to squeeze through any foramens or holes within the skull. Foramen of Monroe. Yeah. Okay. You don't want that to happen because that could kill the person. So what happens is, surgeries are done. Let's say the bleeding, there is bleeding. Let's say the bleeding stopped. You still have a big chunk of blood there that is pushing the brain. And you know, free blood there can also irritate the brain. And what happens if the brain is irritated? It swells up. So even if the bleeding stopped, the brain is irritated, so it will swell up. And when it swells up, it gets larger than normal, so it will still squeeze through the foramen. So what do? You have to drain the blood out, or the hematoma, which is through a Burr hole craniotomy. Basically, what happens is the surgeon will drill a hole through the skull. I wonder if I can. Oh yeah, let's go look at Burr hole craniotomy. You might see some gross photos, by the way, okay? And that's why we're on YouTube. Burr hole craniotomy. That's why we're on YouTube. Here we go. What is a good photo of this? Oh my god, look, there's like a gross photo here. Okay, Burr hole craniotomy means drilling a hole. Here we go, this one is a nice one. Burr hole craniotomy. Okay, there's a new tab. Basically, look, see? Drilling holes in your skull and then draining the blood out. Yeah. That's one. Okay. So, just drill a hole in the skull, suction the blood out delicately, and, you know, put a drain, and you're good. and then you have to just observe the patient, make sure, you know. Eventually, the patient will get better. It will take a while. Yeah. A burr hole is usually just one. Okay, you don't drill holes everywhere. You pick one. Where's the nearest part? So if the bleeding's in the frontal part, you got a frontal burr hole. In the parietal or the temporal, I mean, you drill in the temporal area, and there's a parietal one. Okay. All right. Let's see. Look here. What is this? It's so blurry. What? It's so pixel. Oh, there we go. See? Okay. It's basically a drill. Okay, it's a drill that you like. I should show you guys a video of that. I should show you guys how a burr hole goes, right? Burr hole craniotomy. 12 minutes. Is there like a surgical? Which one would be a good one? Subacute SDH via burr hole. Can I click this? Ooh. Here we go. We're going to look at some gross stuff. Okay. Well, I assume that, you know, since you guys watch my streams, you guys can handle this. All right. So we're gonna look at some burr hole. Let's see. Can I play this?
Let's discuss evacuation of
oh my god,
subdural hematomas.
Wait, let me turn up my
Burr
chatting
holes.
BGM,
This
bro.
is a 45-year-old male who was on an
Bro, this guy, the guy talks like he is he using like an ASMR voice or something? He sounds sleepy. ASMR, neurological ASMR voice. Oh, what? Oh no, it's not loading properly. Okay, let's just like look at the procedure. Oh no, it's buffering. What? Really? Oh wait, is there sound? Hold on. Oh, there we go. Oh, it's buffering. God damn it. Okay, let's just.
Let's go.
Bruh. I can't play it. Oh man. I can't play it, oh no! Bruh, why are you not playing properly? What is wrong with you? It should play properly. Oh no. What if I...
The use of a field.
Oh man, okay, let's look for another video. This sucks. That sucks so bad. Emergency burr hole craniotomy 1. What may pangalan? May pangalan pa to. Okay, this one is a YouTube video.
Hello, my name is Juan Altafula.
Oh, okay, that's why it's called Juan, because he's
resident.
Oh, he's a resident.
From Hospital Santo Tomas, Panama City, Panama. I'm also an anatomy research fellow here at SSF today, and an scalp nerve block.
Is this a...
So, to begin...
what the heck? Is that a...
education example.
Wait, is this a dead... Wait, is this just the head of a person? Whoa, wait, is this a cadaver head? It's literally just a head here. There's no body. What the hell are they doing in where is he from? Seattle? No, he's from Panama. Panama? They get heads. They have just the heads and they practice on heads. Yo! He has a head. Hey, they give head. They give heads to in Seattle. I just noticed it's just a head. Oh my god. Wait, they didn't do this. They didn't give us a head here in they didn't give us a head in med school. Anyway, okay, let's
learn how to do emergency burr hole craniotomy and scalp nerve block. So to begin, as a education example, you are on an island in a private party, and one of your friends decides to climb a palm tree to grab a coconut. So then he falls, hits his head. You, as a medical student, go over to him and examine him.
Oh my God. He gives an example. Okay, let's say you're at a party. And then one of your drunk friends decides to climb a tree and he falls off. We're gonna teach you how to do a burr hole craniotomy on the spot. What the fuck? What? Why will you let your friend climb a tree when he's drunk? Okay, guys. Pag nasa party kayo, when you guys go to parties, make sure you're... In the first place, make sure your drunk friends don't climb trees to get a coconut. So they fall off.
Initially, he's okay with a Glasgow score of 15. No evident deterioration.
Ooh, I have to teach you guys about the Glasgow scoring too.
On the right side of the head. You go back to the party, 10-15 minutes in, your friend starts to deteriorate, he starts to speak nonsense, then become lethargic, and finally he stops responding to stimuli. You go and examine him again, and now you see that he has blown a right pupil. In other words, he dilated the right pupil. So you're gonna have to perform a Burr hole craniotomy, suspecting of an epidural or subdural hematoma. First, there are several sites where you can do burr holes, but the first burr hole will always go ipsilateral to the blown pupil and over the temporal bone. So you get a scalpel, you do an incision right over the skin.
The skull already. The head has an incision. There's no blood, you guys. It's a freaking cadaver. Look, he has a hole already. This is a practice head. It's a head.
Drill, position it over the bone, and start drilling.
Yeah, that is.
It has crossed.
That is literally the drill, but the one we have is more like a carpenter drill. It's larger. So imagine, oh my god, it literally is a head. See, it's a freaking head. It is just a head of a person. Oh my god. So yeah, this is basically a burr hole, okay?
Into a...
Where would you get a scalpel at a party? I don't know. You can probably use a kitchen knife. You never know. What if a neurosurgeon goes to the party? He actually has a burr hole kit with him. You never know. You guys have to have a burr hole kit with you. Make sure you got a scalpel and a drill for ready.
Softer.
No, it's not an electric drill. You gotta do it manually.
That will indicate that the drill has crossed the temporal bone and reached the epidural space. If you are facing an epidural hematoma, you'll immediately access a blood clot, which you can evacuate or release pressure over it. And if you don't see any bleeding or blood cuts, you will continue doing the subsequential burr holes. The next burr hole you're gonna do will be in the temporal side of the contralateral temporal bone. The next one will be a frontal. You just need to remember that stay away from the midline and right anterior to the coronal suture. So the measurement will be almost around like 2 finger breadths lateral and 2 finger breadths anterior to the coronal suture.
Wow.
In a normal person, you could palpate the coronal suture, so depression
Oh wait,
over
can?
the frontal bone. And
I'm like feeling my
third
skull
borehole,
right now if I could feel
find
that, because I've never.
any of the
Oh yeah, you can
bleeding
actually
or
just feel
hematoma
for it.
in
What the
any
hell?
of
I never
these
knew that.
sites will be
I don't do much of these.
parietal
That's
one
why.
right over the convexity. So we will have the temporal, frontal, and parietal one, and also the contralateral temporal one. Two things, because when
Can I
the
use an
patient
electric drill as an
reaches the
alternative? No.
hospital and is taken to the OR,
Oh.
you will be
Okay. All right. That was done. No, you cannot use an electric drill. There's a difference between a drill meant for a burr hole, compared to an actual drill that you use in carpentry. Okay, if you use that drill, you might actually just drill through the brain. Okay. Anyway, yeah, that's basically how the burr hole goes. Okay, just drill the hole through the skull, drain the blood, you're good. Okay, well, we have to bring to the hospital, of course. But I've thank God that I've never had to, actually drill holes like out there, outside a hospital setting. I don't have a burr hole kit, okay? I don't have a burr hole kit. Anyway, that's how it goes. Yeah. I forgot. Before we go any further, okay? There is something I will teach you. This one is, very important to doctors, but it could be useful for people like, laymen. And that is called a GCS scoring, or a Glasgow, coma score. Okay, Google.com. Google. Okay. Glasgow coma scale or scoring. Alright. We use this a lot. Glasgow coma scale or the Glasgow coma scoring. We use this a lot. Especially when we're considering any injury or to the brain or strokes. Actually, even if it's not an injury to the brain, or even if it's not a brain injury or a stroke, we use this. Let's see. Let me look for a very nice, a better. Let's see. I think is this the one? I think, yeah. This is very pixelated. What the hell? Why is it so pixelated? It's so pixelated. What the heck? Oh, this one. Oh, here, this one's better. We'll use this one. This is much better. Okay. You haven't used a drill. No, I did. I've used a burr hole drill before, okay, but not an actual drill, bruh. Okay, this one. This is very important, okay. This is how we assess a patient's sensorium or consciousness. This is very useful. I mean, I think even as a layman, or even if you're not a doctor, this could be very useful for you. This is what we call a GCS score, or a Glasgow coma score or scale. Shortcut is GCS. All right. It's a score that we use to assess a patient's sensorium or consciousness. It is divided into three sections, the score, which is the eye opening, so we call that the E. E, V, and M. Eye-opening, verbal response, and motor response. Okay? That's why when doctors talk about GCS, they would say, okay, the patient is GCS 11, E4, V1, M6. See? You have to specify each part. So for those who are in med school, or those who need to memorize this, as a doctor, you will definitely be using this a lot when you become a doctor. So you'll be using it so much that you're gonna memorize it, alright? You're gonna use it so much that you're gonna memorize it. Just remember that it's just EVM 456, okay? So, E for eye opening, the highest, okay, in a GCS score or a Glasgow coma scale, the highest score you can have is 15. Because if you add it 4, 5, and 6, it becomes 15, right? That is the highest score. The lowest score that you can have in a GSCS is 3. Okay? So, what is the difference? If the doctor says, GCS 3 na siya, so that's an E1, V1, M1. GCS 3, he's GCS 3. That is the lowest. That means, that is the lowest score. That means the patient is unresponsive. Look, see, 1, no response, does not open eyes. No response verbally, does not answer you. No response by movement. So, totally does not respond. These are the ones who are comatose, brain dead, you know. It is the worst possible score. The opposite would be 15, wherein they have spontaneous eye opening. They speak to you, they answer you, they are oriented, they know who they are, they know where they are, they know what time it is. And motor response, they obey, they understand and can obey. If you tell them to do something, they'll do it. So it is the highest. It's basically like you know, when you're speaking to a person, when you speak to your friend, when you speak to someone, if you are able to communicate well, you're awake, you're alert, that's GCS 15. Normal. Okay, that's normal. Okay. So, what if you have let's say you have a patient, okay? You have a patient who has a decrease in sensorium. He's not totally normal. Like when you talk to him, like his eyes are open. Let's say his eyes are open. He's looking around. But when you talk to him, when you talk to that person, he just says nonsense words. Like he said he can speak. He can speak, but they don't make sense. And then when you tell him to do something, he doesn't follow you. But when you rub his chest or the sternum, he moves his hand towards it because it's painful. What score would that be? So you got spontaneous eye opening, so that would be an E4, right? And then verbal response. When you talk to him, he just speaks nonsense, so inappropriate words. So you have V3. So E4, V3, and then when you tell him to do something, he doesn't follow it, but if you rub on his chest and it hurts, he will put his hand on the chest, the area you're rubbing. So he localizes where the pain is. So that's a 5. So what score would that be? That would be E4, V3, M5. So 4 plus 3 plus 5 would be a GCS 12. Oh ba? GCS 12. It's by math, right? 4 plus 3 plus 5. Oh wait, no. Is it 12? 4 plus 3 plus 5. Yeah, GCS 12. Okay. So, Yeah. How do you, how do you test for GCS? For a score? Well, the first thing we do, like, for example, we get a patient, also, by the way, so this is for patients who have a decrease in consciousness and sensorium, right? You gotta, as a doctor, especially as a trauma doctor, if you're gonna handle patients that come in the ER and you're a surgeon, okay, you have to be aware that not all patients who come in with a decrease in sensorium means they have brain damage, okay? Like, someone can come to the ER or come to you wherein they don't open, their eyes are not spontaneous, they don't open their eyes. They just only react. They only open it to pain if you pinch them or if you rub their sternum or their chest. They open it. They don't speak. So they would just have no response. Or sometimes they don't obey you. They'll just localize their pain. So what is that? That would be an E2 V1 and M5. E2 V1 M5. That would be a GCS 8, right? That's basically half. Usually when you're on GCS 8, a lot of the times any patient that's below GCS 9 or GCS 9 and below, we have to prep them for intubation because most of the time they would have a hard time breathing. But as a trauma doctor, if you see patients, you gotta be aware that not all patients who have a very low GCS are because of brain damage. Okay? Why? Especially if you get their history and you find out, you extract from their history that they have been drinking all night long. Okay? Drunk people can come to the ER as a GCS 3. Okay? Or GCS 4. I have had a lot of these people. Okay? I had a lot of these people. Like, the nurses will call me, Doc, may pasyente dito nahulog. Head trauma. GCS 3 na po, Doc. I'm like, what? GCS 3 po, Doc. Nahulog po sa nahulog sa puno. He fell down a tree. GCS 3 nung dumating. Pero amoy alak. But he smells like alcohol. They would tell me, he fell down a tree. He's unresponsive, but he smells like alcohol. I'm like, oh my god. Okay, I have to go there. And then I check the patient. Once I get there, I check the patient myself. Sometimes it's not GCS 3. Like, you rub their sternum hard enough and they'll react. They'll react by being pissed off at you. Like, they will move their hand to their chest and, like, try to swat your hand away. Okay? They will try to swat your hand away. I'm like... And I'd be like, okay, to the nurse, okay, this is, he's not GCS 3, he's reacting. And you can smell the stench of alcohol. And then you just have to ask the person who brought the patient here, like, has this guy been drinking? And they're like, opo, yes po. Ang daming na inom, siguro mga 6 na boteng gin. Or something like that, you know? So, yeah. All you gotta do is just hydrate them. Well, but of course, even if you know that they have been drinking, even though they have been drinking so much, you gotta be safe. As a doctor, you still gotta rule out head trauma because even if he's drunk as hell, he still fell off a tree. Okay, you can still suffer an injury. Like sometimes I get people like that. They're drunk, they fell off a tree, and now they're bleeding. They're bleeding from their heads because they have a laceration. You still gotta do a cranial CT scan, okay? Just to rule out any bleeding, okay? So just to be safe. So once you rule out any bleeding within the brain, then you can, it's safe to say that, yeah, he's just drunk, that's why he's like that. And eventually, like the next, give it like until the next morning, and he'll be awake. He'll be awake as if nothing happened, and he won't remember anything. He'll just be wondering why he's in the hospital. He'll just be wondering why am I in the hospital? How you just casually fall off a tree? Well, he was drunk. He wanted to climb the tree because he's drunk, and he just fell off. Okay. I mean, I had one. Okay, I have one example. Okay, one example. This one is a really funny one, by the way. One patient was taken to the ER. He was drunk. He was drinking. The story. When I talked to him, okay. The story was from the other people, the ones who brought him in. He was drinking. He drank a lot. He got on his motorcycle and started to drive. And then he got into an accident. Okay, and of course he lost consciousness. After the accident, and he suffered multiple abrasions on his body and has like a bump on his head. Okay. He was taken to the ER, and the ER he was awake but very sleepy, very drowsy. Okay, so his eyes. So what would be the GCS? He is very drowsy. Like if you go to him, his eyes are not spontaneously opening. So you have to. If I talk to him, I'll be like, "Hey, sir, can you open your eyes?" He doesn't respond. So you have to really, rub on his sternum, induce pain, and then that's when he'll open his eyes. And I'll be like, "Sir, kamusta kayo? How are you, sir?" And then he'll just be like, "Ugh." Or okay lang ako. I'm good. I'm okay. So, and then you start asking him, do you know where you are? Or, you can ask him just to know if he's oriented to time and place. And then motor response, if you tell him to do something, sometimes he won't do it, but if you do a sternal rub, he will localize the pain. So he's kind of awake but not normal. Right, so that was the story. But when I talked, so he was right. He drank. He rode his motorcycle and got into an accident. Okay. When I talked to him, so I was able to elicit that he would open his eyes to pain. And I asked him, "Sir, what happened?" And he would tell me. Okay. He would say, "Kasi," he said this, okay, and I kid you not. He said he was just standing there. Andun lang daw siya, nakatayo lang daw siya sa tabi. This is what he told me. Nakatayo lang ako sa tabi. Tapos, and I'm like, okay. Tapos, ano nangyari? Like, what happened? Tapos, sinagasaan ako ng eroplano. I'm like, wait, what? wait, what? What? Like, what? He's like, wait. He said he was just standing on the side, and then he got run over by an airplane. I'm like, wait, what? Like, what? How did that happen? I'm like, teka lang, sir. Wait lang, sir. I'm like, wait, you were just standing on the side and you got hit by an airplane? And he's like, "Opo, ma'am. Opo, doc." I'm like, yes, sir. Yes, ma'am. I'm like, why were you? I'm like, why did you get run over by an airplane? And then he's like, "Kasi nakatambay lang ako." He says, "Cause I'm just bumming around." Yeah, it happened. I'm like, when he told me that story, I was like, did you drink? I'm like, nakainom ka ba? Did you drink a lot? And he's like, yes po. I'm like, okay, what did you have for drink? And he just told me like, mga emperador or whatever. He just tells me. I'm like, I see, okay. And I like tell the nurses, okay guys, Hydrate the the nurses heard that story, got run over by an airplane, and they were laughing their heads off on the station. Could be a toy airplane. He was drunk, okay? He was drunk and he just said he got run over by an airplane. The next morning when he was sober, I asked him, do you know what happened to you? And he's like, no, I don't remember. He couldn't remember anything, okay? He couldn't even remember what he told me. I'm like, do you know what you told me last night when you came to the ER? Do you know what happened? And he's like, no. You know what you told me? It's like, oh no, what did I tell you? I said, you told me that you were just standing there, you got run over by an airplane. And he was like, oh. So yeah, you know, drunk people, okay? Drunk people, they can, if you cannot detect a drunk person, they can throw you off with a GCS score, okay? Alright. Let's see. Okay, what did I talk about? I already talked about the anatomy. I talked about aneurysms. Oh, okay. And I talked about stroke. Yeah, stroke. Infarct versus bleed. Usually the ones we do surgery on are the bleeds, okay? Burr hole craniotomy. What else? And then the GCS scoring. Yeah, that's a chunk of it already. Do you guys have any questions? Anong klaseng aeroplano yung Cebu Pacific? Hindi ko alam. You should have taken a video. No, I cannot do that, man. That's against the law. I'm not allowed to, we're not allowed to do that, you know. I can't, and even if I did take a video, I'm not supposed to spread that around, so I wouldn't. I can only just tell you stories. I cannot show videos. That is, against the Data Privacy Act, you know. And besides, it's also because, you know, he's still a patient. He may be drunk, he's still a patient, and that's a confidentiality between doctor and patient. This is why if I do tell you about my cases as a doctor, I don't give out names. I will just tell you what I experienced, but you know, no names. If it's my friend, he'll film. I mean, I can't film that, man. Lobotomy. Guys, lobotomy, that is a very outdated procedure. Okay, come here. You guys... Lobotomy is something that is not done. Okay? It is a very, outdated procedure. To be honest, I have not seen lobotomies done, at all. But, even it's not lobotomy is lobotomy is not something neurosurgical, or it's not under a it's not a treatment for something that is a neurosurgical. This is more of a psychiatric thing. Okay? It's a psychiatric. It's if you do a lobotomy, you can change a person's psyche or calm a patient down, something like that. So, I have not seen this done at all. It is rarely done. I have not seen it done at all. Okay? Oh, see, look at this. Used in a treatment of epilepsy or severe mental illness. This is not done anymore. Because in epilepsies or seizures, you just give them medication. There are anti-epileptics that people can take. And, mental illness, it's medications. Alright? Yeah, huge ethical issue. Yeah, I've read about the history of lobotomies that, you know... there we go. See, worst surgery in history. Lobotomies are, It's not done. Okay. This actually does actual brain damage rather than cure anything. Oh. If that's happened, Shiori's cancelled. Man, the chat's delayed on my end again. The chat is delayed on my end again. I hate YouTube. I really need to find out how to fix YouTube so that my chat doesn't get delayed. Like, the chat is delayed on... I know, it's not that the chat is delayed. It's my stream that's delayed on your end. So that's why the chat looks delayed on... For me. My stream is delayed on your end. Okay. So, yeah, this is not done anymore, so... I've never seen lobotomies done, because it's something that's not done anymore. Guys, have any other, any other questions? Because, I think that's basically it. Oh. Hello, Deandro. YouTube is a lost cause. Yeah, but, you know, YouTube is still useful for me for medical education streams. Like, see, I can show you gross photos or gross pictures here on YouTube rather than on Twitch. On Twitch, if I did that, I'd probably get, like, I don't know. I'll get in trouble for that. How about the one where people zap their head? What do you mean zap their head? Huh? What do you mean by zap their head? Zap their head? Specifier. Tell me what you mean by that. What's up with brain freeze? Brain freeze is... You know, I never actually looked up, the, pathophysiology of a brain freeze, you know? I just know that if you, I think, well, but if I think about it, something that's so cold, your brain, perceives something so cold that it hurts. What the heck? Temporary mental confusion or failure to perform. I didn't know there was another meaning for brain freeze. I never actually looked at the pathophysiology of that. You know, brain freeze? Let's go look at it. But I was thinking, something is just so cold. Your senses that it you know, when something you taste is so cold, you know how you know, the nervous system works? Any sensory, anything you sense, gets sent, the information gets sent back to your brain, and then your brain will translate it for you. So, man, I don't know. I'm just guessing right now. Without reading this, I'm just guessing that something is just so cold. Let's say you eat an ice cream, like a lot of it, and your tongue or your mouth receives all the cold sensations, and it sends in all that information to the brain that it hurts. That's what I think, man. Okay, let's look at the intense pain from the front part of your head, blah blah blah. Cold stimulus headache. Ooh, I didn't know this one. Look at that. There is an actual medical term for a brain freeze, and I didn't know that. Sphenopalatine ganglioneuralgia. Ooh. This is actually new to me. So you can see, you know, if you want to sound like a pro, you know, oh god, I got brain freeze. Instead of saying you got brain freeze, you could be like, oh god, after eating your ice cream, oh no, I got sphenopalatine ganglioneuralgia. You can be a total nerd to your friends right now, guys. You be a total nerd to your friends instead of saying I got brain freeze. I got sphenopalatine ganglioneuralgia. Okay. Is there like a... When your blood senses sudden extreme cold in the mouth or throat, tries to act and warm up, blood vessels throughout the head expand to the extra. Oh, okay, okay. Ah, okay, I see what happens. It's totally different from what I thought then. So, you experience something really cold and your brain, since the, well, it's not totally different from what I said, but it's parang kulang, it's just lacking. So, you experience something very cold, or feel something very cold, the signal gets sent to your brain, and your brain just thinks, oh my god, it's cold! The brain just says, oh my god, it's cold, we gotta warm it up, we gotta warm it up. So what happens is, the blood vessels, dilate to let more blood in, and if your blood vessels dilate to let more blood in, it can cause a throbbing headache. Like a migraine. To warm the area up. There we go. Okay. Okay, and then back to that one question about zapping your brain or your head. Doctors zap their patients in this. Electrotherapy? Is that the one? Electrotherapy? Is that what the one? Shock therapy? Is this the one? I'm not sure if this is the one you guys are talking about, okay? No, electro... Oh god, I'm in Wikipedia, no. Shock therapy? Is this the one you guys... Oh wait, this is not the head though. We should go to Google. Google is bad. Why am I on Bing? Electroshock therapy. Is this the one you guys are talking about? Electroconvulsive therapy. Involves sending electric current through your brain, causing a brief surge of electrical activity. I think this is the one you guys are talking about, right? I have not seen this done, actually, to be honest. And this is not a neurosurgical thing, which is probably why I have not seen it done. It's more in psych, but this looks like it's more for psychiatric patients. I have not seen this. I have seen this like in movies, but I have not seen this done in real life. Cause when I was in medical school and then we handled psychiatric patients, we just, you know, the therapy given to them is just medication, and behavioral therapy. But nothing like we have not seen an electro shock therapy. Oh, this one. Let's look at the deep. Let's look at it. Oh, okay. There's a stigma. Okay. Oh, there. Probably, okay. I have not seen it done, but I guess during the earlier days, it was more, you know, dangerous. But now they're able to regulate the shock given, so it's safer now compared to before. But yeah, I have not seen this. I haven't seen this actually done. So I cannot really give a comment. I can't give my opinion on this, to be honest. I really can't. Okay. Can tasers or even electric shocks affect the brain? Yes, it can. Electric shocks, I think there, for stuff like this, there is a given, voltage, maybe? A certain voltage that you have to use. You can't give too high of a voltage, and at the same time, you can't give too low of a voltage. But it is a therapy for psychiatric patients. So I guess it says here for those who are not, for those with severe, mental disorders, when conservative treatment didn't work. So yeah. Oh, it's the dark ages of medicine. Yeah, like the old times, but since medicine is always evolving. Okay. Medicine is a science, and you know how it is. Science is always evolving, or science is not permanent. There is nothing permanent in science. There's always new information, new researches. There's always something new. It's the same with medicine. So, like before, for example, certain therapies were the gold standard, or this is how you treat a certain disease, but then, after time passes, you find out, oh, there's a better way to treat a person's disease, right? Okay. What about signs of concussion? Basically, signs of concussion, that's history of a trauma, and, the GCS score. Wait, we're gonna go back to the... You can tell the GCS score is one of the good ways of finding out, for concussions. As long as there's a history of trauma, and, there's a history of trauma, and then there's a decrease in sensorium, you have to observe the patient. You'll know if there's a concussion or an injury to the brain. Okay? And once there's an injury to the brain, you cannot exactly, describe what kind of injury it is until you do a CT scan. So, yeah, I didn't discuss anymore, what are the different types of, bleeding in the brain. Because either way, if you have bleeding in the brain because of a trauma, the treatment is the same. You have to get the blood out. Okay? It's the same with a stroke. If there is bleeding in there, and if the bleeding is much too big that it's pushing the brain, you'd have to do a surgery. Oh, and by the way, also, I forgot to mention this, but it's a how do I say this? Good to know. How do you know if someone is having a stroke? Okay? How do you know? So, let's say someone older than you is working, and suddenly he just falls down. How do you know the difference between a heart attack and a stroke? A stroke is always, by the way, stroke is a brain thing, okay? It's not a heart attack. Some people confuse stroke as being a heart attack, but it's different. Okay? A heart attack and a stroke, they would usually they would fall, right? They're doing something and suddenly they just fall to the ground. And sometimes they just become unconscious for a while, or they complain of pain. So in a heart attack, they're usually they will complain of chest pain. Okay, they will fall to the ground, complain of chest pain, and probably just be suddenly, they'll complain of chest pain, they'll fall to the ground and suddenly lose consciousness. Okay. And when you feel them, they are cold and clammy. Their hands are cold, For a stroke is more, how do you call this? They will complain of a headache. Alright? Or anything related to the brain, or headache, dizziness. Usually headache. They will say, my head hurts, or my head really hurts so bad. So after that, some people who have a stroke, if they don't fall down or lose consciousness, they will say they have a headache, and then they'll probably like try to sit down, and they'll suddenly feel weak. Okay? And almost always, the weakness is on one side of the body. For example, he has a headache, and then suddenly that's actually the reason why they fall, okay, or lose balance, because they are suddenly weak on one side of the body. So they will tell you, nangihina yung right side, yung kanan ko, or their right side is weak, suddenly becomes weaker than the left side. So that goes for their arms and their legs. Or sometimes when you talk to them and they answer, you don't understand them. They have a slurring of speech. Like they'll say, like, you ask them, are you all right? And they'll be like, they'll be like that. Slurring. Okay. And then usually okay, if they experience weakness and it's only on one side of the body, and they have the slurring of the speech, almost always it's a stroke. Okay? So there is a difference between being generally feeling general weakness of the body. Okay, general weakness of the body. There is a difference between having a general weakness of the body compared to a one-sided weakness. Okay? So that's the difference. General weakness of the body, it can be related to the heart. But if you have a weakness that is just on one side of the body, like only on the right or only on the left, and then you have slurring of speech, you gotta consider a stroke. Okay? And if you are considering a stroke, it is an emergency. Bring the patient. If you think someone is having a stroke, bring the patient to the emergency room as soon as possible. Okay? Because they may be awake at that moment you saw them fall down. They may be awake and they may say, I'm okay, but then they can't move the left side or the right side of their body. No, take them to the emergency room. Okay? Because they may be awake and they can understand you, or you can talk to them at that moment, but give it just a few hours, an hour or two, they will have a decrease in sensorium, or you won't be able to talk to them properly, especially if that is a bleed. Okay? Bleeds from strokes and traumas, they are very rapid. Like, they will be okay on the first moment. They will seem okay, but then give it an hour or two, you will notice that they're just sleepy, or they can't talk to you properly. You'll notice that there's something wrong. Okay? You'll notice there is something wrong. And if it's an active bleed, give it 6 hours or more. They won't be responding to you anymore. So yeah. Oh yeah, I remember my uncle getting a stroke during Christmas the other year. We had to rush him to the hospital. He went inside the restroom to relieve, but he suddenly opened the door and he said he's really groggy and about to fall asleep. We had to carry him out to the living room and had to keep him awake and steady till the first responders arrived. Oh yeah. There are some people who are just like that. You just feel sleepy. Okay, you'll notice if you suspect the stroke, bring to the ER as soon as possible, okay? Do not delay. Because if there is an active bleed, they have to be able to control the bleeding, okay? They need to be monitored very closely. Okay? Is that related to Bell's palsy? Bell's palsy is different. Bell's palsy is that's on the face. It's when I say weakness on one side, I mean like the entire side of the body. Because let's say what do you call this? If you have a stroke, if the bleed is on the left side of your brain, the presentation is always on the right. Okay, it's usually like that in neurology or neurosurgery. If the bleed or the lesion is on the left, the presentation will be on the right. So, if the patient had a stroke and has a weakness on the right side of the body, most likely the damage or the lesion is on the left side of the brain. Emergency first-line management for suspected spinal cord injury is discovered in not really. We usually handle the brain stuff. The spine is under neurosurgery, but can also be under orthopedic surgery. So that one is more specialized. The spine is very actually, to be honest, spine is a lot harder than brain because spine has different levels, and for each level, you'll know which parts of your body are affected, something like that. Spine is something that's difficult for me. That one's difficult. Yeah, I'm not good with spine. I'm not really that good with spine, but that one is a whole other subject. That is another subject. Okay, but yeah, I think we're good. We're good. And yeah. Oh, is it a subarachnoid hemorrhage with a lucid period? No, it's not necessarily a it's not a subarachnoid hemorrhage. If I remember correctly, a lucid period, that one is more on epidural hematomas, not subarachnoid hemorrhage. I hate spinal tract. Yeah, I don't like the spine either. Spine is a whole different subject. It's a whole different subject, okay? So, I don't think, if I ever do a medical education stream, I don't think I'll be able to do spine. Because I do not have much exposure to spine. Like, the only... Because, you know, we usually just refer that, if it's a spinal injury, we just toss that to, like, orthopedics or, like, directly to the neurosurgeon. But usually orthopedics, yeah. Okay. Alright, and I guess, I think we're good. We're good. It is 11:40, so yeah. I will. We took longer than I thought. I thought we were only gonna last an hour. We took an hour 40 minutes. All right. Thank you everyone. For coming to my stream. This is actually very a scuffed medical education stream because I had no PowerPoint presentation ready for this, and other than that, this is a topic that is not my forte. So I tried my best. I hope you guys learned a lot. I'm sorry again for being late. This was supposed to start at 9 p.m. I started at like what? I started at almost 10. Yeah. So I hope you guys learned a lot despite the scuff. I will be streaming tomorrow on Twitch. So for those there who want to watch more of me, because I know there are a lot of people who come to my YouTube medical education streams and they would be like, I missed you, I haven't seen you stream in a long time. And like oh wait, I stream on Twitch, that's why. I stream on Twitch. I am more active there. Medical education streams are done here on YouTube, which I do or try to do once a month. But I play a variety of games on Twitch. So I am more active there. I stream on Twitch at least 3 times a week. So I'm there. Okay. Play different games. If you wanna follow my Twitch, you can just look at the description below this below. It's there. Okay. And yeah. We're good. Otsukareya. Otsupon. Thank you so much, everyone. And yeah, have a good night. Next medical education stream will be next month. Okay. I will think about what topic to talk about. But yeah. Alright. Otsupon! Goodbye! Good night, everybody! Bye-bye!